to the Home of Medicine podcast with me, Dr. Amy Burbridge, and
me, Dr. Ben Lovell. Nice to see you again.
Nice to see you in this beautiful sunny weather that we are experiencing at the moment.
Well, it's too hot, so I have left the little window open. So if anyone hear birds cheeping or lorries passing by, maybe it's add to the ambience of the podcast, but it's stiflingly hot here. I had to let some oxygen into the room. So apologies in advance if there's any sort of interference from the outside world.
Fine. I've got a case for you, Ben. Are you ready?
Yep, I'm ready.
So, 23-year-old male who presents to the same-day emergency care unit via A&E. So he's seen in the emergency department and streamed down to the SDEC area. He's been unwell for 2 weeks with a sore throat, fatigue, generally unwell off his food. Doesn't normally get unwell, no real significant past medical history of note. And he also says that his right shoulder is hurting, his knees sore, and his thighs sore. So he's just got this generally sort of achy joints in his body, but particularly in the shoulder, the knee, and his thigh, and a bit of a sore throat. Any thoughts?
Okay. So common things being common, this might just all be a constellation of presentations of an acute viral illness, which will be self-limiting and doesn't need really too much interference from a medic. Sore throat, fatigue, poor appetite, the shoulder pain, the knee pain. I mean, you can get generalized sort of myalgia when you have a virus infection, although it sounds quite specific. Right shoulder, did you say right knee?
Right knee.
Right shoulder, right knee, and right thigh.
Mm-hmm.
So usually viral illnesses cause general malaise, general myalgia, not so much arthralgia, myalgia. So that's a bit funny. It could be that he's got an acute viral or acute infective illness, and he's got a reactive arthropathy secondary to that. So we will have a look at these joints a bit later, I'm sure. But that's my thinking at the first instance. Any more thoughts from Ben? Sore throat, fatigue, poor appetite, right shoulder, knee. Right down the bottom of the list is an acute presentation of a rheumatological illness. He's 23,
Mm-hmm.
and that's rare, but it's possible. It's,
Yeah.
exam question, it'd be higher, but in the real world, people tend not to present emergently with a new diagnosis of an autoimmune rheumatological condition. But it's something that would be on the list, albeit it's not near the top.
Yeah, absolutely. So, yeah, that was my sort of thought process as well. However, when the we came to assess him, he actually looked really unwell. And you know when you look at somebody from the end of the bed or the end of the chair, wherever they are, and you just get that feeling that, oh, they look sick. But you don't know
Mm,
why. You can't really put your finger on it. And I often find that young people don't look sick until they're really sick
mm,
because they're usually fit and well, working, no problem. So, on further sort of questioning, he said he'd been a little bit short of breath for about a week and had a bit of a cough with a bit of productive sputum, but nothing really of note. He said there was no hemoptysis. He denied chest pain. He denied palpitations. He'd had a bit of a generalized headache all over his head, but there was no sort of like pinpoint area for the headache that he'd noticed. His vision was absolutely fine. He said that he was generally tender all over his muscles in his body as well as the shoulder and the knee and the thigh pain, which was much more painful rather than a tenderness that he noticed. No bowel or bladder problems at all. So bowels and bladder normal. And as I said before, his appetite was a little bit off, really because his throat was so sore he couldn't really swallow. No past medical history of note, didn't take any medication at all. He was a smoker, so he smoked around 5 to 10 cigarettes a day, but also vaped on top of that. And there was an occasional cannabis usage as well. And he denied any other form of drug use. I asked specifically about cocaine, and he said he didn't take cocaine or any of the other medication, any of the other drugs. And no family history really. He worked as a car mechanic, pretty fit and healthy. So he looked ill. So on examination, his observations, his saturations were 97% on air. His respiratory rate was 22. His heart rate was 124. His blood pressure was 104 over 67. Temperature was 39.2. Any
Mm.
concerns at the moment?
I'm thinking about what you say about looking unwell. I remember reading a while ago that what do doctors mean when they say someone looks unwell? And when it's sort of that diffuse, we can't really put our finger on what we're trying to say. They just don't look right. Apparently, what we're noticing and what we're trying to put words around is we've noticed that they've activated their sympathetic nervous system. So they look maybe a bit shaky, restless. There's a sort of a sickly sheen to their skin because they're sweating. Maybe we can pick up that they're slightly tachypneic. We have a good sense, human beings, of what someone's general resting respiratory rate is, and we can sort of subconsciously notice if someone's a bit more breathless than usual. And that's the sort of subconscious triggers that we who see a lot of patients that we sort of pick up on. We say, oh, they just don't look right. They just don't look right. We're actually noticing adrenaline. We're noticing the sympathetic nervous system and the secondary effects of that. And I think that's echoed quite nicely in the obs you give me here because he's tachycardic, his blood pressure is low, and he's febrile. His respiratory rate's 22. It's really not too far out the bounds of normal, but that's a high heart rate. Now you can get tachycardia with fever. I mean, you last time I had the flu, I'm sure I was tachycardic and febrile and looked absolutely dreadful for a while. So this could all be flu still. It could all be viral, but that would explain why he felt and looked so unwell. Now, in the olden days, this would trigger for sepsis because we used to have a little checklist when someone came in and he would get a tick for heart rate and fever. And this would then trigger SIRS. This is a systemic inflammatory response syndrome. And then we'd be looking for infection signs. You've got one, productive cough. And this would actually trigger chest sepsis. And this is a good few years ago now, where we went through a little phase in UK medicine of sort of making algorithms and a checklisty response to sepsis. And we now appreciate it's a bit more complex than that. But this would be someone who would normally get sort of triaged quite quickly for urgent bloods, consideration of a dose of IV antibiotics if it felt to be bacterial in cause, and maybe a fluid bolus as well. And the good old sepsis 6. So looking for lactates and blood cultures and urine outputs and things like that.
Okay, so what do you want to do? You said that you want to do antibiotics and what any other tests that you'd like to do apart from a blood gas?
Sure. I'd like to drill down on the chest symptoms. So he's got a
Okay.
productive cough, a fever, and tachycardia. So has he got pneumonia? So let's get a chest X-ray. And then our usual sepsis, sort of query sepsis blood panel. So full blood count using these and a CRP. I don't do ESRs, just an institutional thing. We do CRPs. And let's get IV access since we're going to be getting bloods because this is someone who may need intravenous either antibiotics or fluids or both in the near future. And of course, we'll get a VBG. I don't think we need to get an arterial blood gas because he's not hypoxic, but a VBG for a lactate would be super useful here as a bunch of baseline tests. So get himself an ECG as well because of the tachycardia, which I'm sure will be a sinus tachycardia, but we'll square that away as well. And we ought to do blood cultures since we're going to be sticking needles in veins.
Brilliant. Okay, so those were all done, and I can reveal the results to you. So his ECG showed a sinus tachycardia, as you suggested. The white cell count was 22, the neutrophil count was 19, the CRP was 232, his platelets were 94, so on the lower side.
Mm,
His lactate was 3.2,
mm.
and the chest X-ray showed bilateral, sort of like nodular changes within the lungs, nodular opacities.
I notice you're not saying consolidation.
It was I've got the image in my head, and they're they're very well circumscribed. It is like not consolidation, because consolidation always appears a lot more widespread maybe, but these are very clearly delineated opacities, sort of nodules that you could say was like a circle. It was very circular within the lungs.
Wow. So consolidation, we talk about air bronchograms, we talk about
Mm.
cotton appearance, but you're saying this is something else.
Yeah, very different to consolidation. Couldn't make out any air bronchograms.
Mm,
And the consolidation, normally you would expect, well, there wasn't anything at the bases, and it was bilateral as well, which is unusual unless you've
mm.
got something like ARDS or COVID originally. So yeah, quite nodular. There was two or three of these nodular opacities within the lungs.
All right. So unusual chest X-rays.
Yeah.
Obviously, a chest X-ray is a two-dimensional representation of a 3D structure, and they're really useful, and everyone gets them. We do too many of them. But if you have a chest X-ray which you can't diagnose or is unusual, then you're looking for what we call cross-sectional imaging. So we're looking at a CT chest. But while we're teeing that up, let's look at what we have got. We've got a cough, which is productive of sputum. Did you say green sputum or did I make that up?
You made it up. It was dirty coloured sputum.
So we've got a productive cough, a fever, a tachycardia, and a borderline hypotension and a raised lactate, all hallmarkers of sepsis. We've got a CRP of 200 and something, and we've got an elevated white cell and a neutrophilia. So we've got some really, really good evidence of an ongoing infection. And in fact, we've got really good evidence of an ongoing bacterial infection. And I think we're well within our rights here to be giving antibiotics. I think it'd be I could see why someone would choose to hold off. I think you're quite brave, quite bold to hold
Mm.
antibiotics at this point and say, well, let's see, we don't know exactly what the source is yet. Let's just see if it declares itself. We'll see what we culture. Me, I'd be going with broad spectrum antibiotics, and what we use in our institution would be IV cefuroxime, which is for infection of unknown origin. So I think I'd be making a plan at this point. IV cefuroxime, one, after we've got all our cultures, which are hopefully cooking in the lab. I would like to I would like to give some fluids. Now, IV fluids, why am I giving IV fluids? He's got a tachycardia, which
Mhm.
might be secondary to hypovolemia. The blood pressure is low. It might be due to incipient sepsis, which is, of course, is a distribution issue. So you get vasoplegia and vasodilation, so your peripheral resistance decreases, and that's why your blood pressure goes down. And in the first line treatment we give is fluids. Someone goes into septic shock and fluids are simply not bringing the blood pressure up. That's when we call our colleagues in ITU and HDU and they give vasopressors to squeeze those peripheries closed again. But at the moment, I think we ought to give some fluids. There's been a lot of evidence coming out now about fluids and how doctors often give fluids based on vibes as opposed to hard data. We used to give fluids, well, I think still do give fluids quite a lot for high lactate, because what I was taught at medical school, which made a lot of sense, was that lactate was the end product of anaerobic respiration. If you're hypovolemic and you're poorly perfusing your organs and your peripheries, they move from aerobic to anaerobic respiration, and then the lactate goes up. So you see a lactate, you give fluid and you bring that lactate down, you give enough volume to switch back to aerobic respiration. And we now know that's actually not quite true. And in fact, that can lead to harm. Have you heard of the Lacto-Bolo reflex?
No,
I might have brought this up previously.
I've never heard of that. Tell me about it.
Yeah, the lacto-bolo reflex is a reflex that doctors do. It's a reflex for us. And it's we see a lactate and we give a bolus of fluid. Lacto-bolo. And it happens quite a lot. And I still think, oh, and so Ben, I saw this patient that the lactate was up. So we've given a bolus of fluids and we'll recheck the lactate again. And very much the understanding is we're diluting the lactate here. We're trying to bring the lactate down. And the lacto-bolo reflex is kind of a jokey phrase, but you can read a lot of interesting papers about it, mostly from ITU, saying that maybe we need to break this reflex because it does lead to premature closure and it stops us from thinking. And in fact, giving lots of fluids for a persistently high lactate can result in iatrogenic harm. You can end up overloading a patient, tipping them into heart failure, chasing a lactate, which is not going to come down until you've addressed the actual problem driving the lactate, the sepsis, the infarcted gut, whatever the actual issue is. And the lacto-bolo reflex is an example of sometimes a cognitive bias where we stop thinking and we just keep giving fluids. I've certainly done that quite a lot over my career, and I can understand why you would do it now, because that explanation of the anaerobic respiration, the lactate production, therefore give fluids, is such a beautifully comprehensive little model, isn't it? And it's easy to work from it, but actually it doesn't always ring. It's not always the truth. Does that sort of make sense? Have I explained it?
Yeah, absolutely. And it's certainly something that I am guilty of or have been in the past where you see a lactate of 4, 5, 6, they may even be on metformin, and then you get even more worried.
Mm,
Not that
mm,
again, there's been research to say that there is no link between metformin and high lactate. And again, that's debatable, but 100%. And I still see it now.
mm.
Probably as well because we see the high lactate with sepsis quite often, and one of the sepsis six is to give IV fluids. So it's multifactorial, isn't it? We're giving fluids probably.
Yeah, and I've certainly even before now. Sometimes you see a high lactate and you give frusemide. You're like, yeah, they've got a very high lactate. They're in severe heart failure and renal failure. We need to contract the volume and watch the lactate go down. Watch the creatinine paradoxically improve with frusemide. So we go against a sort of received wisdom quite a lot, and it's important to know what our cognitive reflexes are And they often work and get you out of a tricky spot very quickly as a rule of thumb, what we call a heuristic in medical thinking. But it's nice to know where they are, so sometimes you can challenge them in yourself.
Mm.
So there was my little digression there about fluids. However, I'm going to give this guy some fluids. Do you think he looks dry?
Yes, I mean, well, I mean, he hadn't been eating and drinking very much because of the sore throat. He was tachycardic. His blood pressure was a little bit low, and he looked dry. And you have like the crusty mouth around the edges, and the lips looked dry, and the tongue looks dry.
Mhm.
So, and I know, when I haven't been this unwell, but when I have been unwell, you feel really dehydrated, and you want fluid, don't you? So, yeah.
I was thinking about fluid assessment, and I remember when I was a trainee, maybe F1, F2, and I had a consultant who would always feel a patient's armpits to see if they were.
Oh,
Yeah, he says because if
lovely.
they're in a really hydrated patient, their armpits will be dry, no
Oh.
matter even if they have a fever and they're very unwell. And it's not something I've adopted, I have to say. You just reminded me of that. When we're assessing for dryness, we often look for skin turgor mucous membranes. I wonder if anyone there has a good rummage around someone's armpits just to see. I personally don't.
No, it's not something I do. And I guess you've got the problem there is if somebody's put deodorant on, they're not going to be sweaty, are they? So I'm not entirely sure of the validity of that assessment. But so, anything else you'd like to know?
Right, let me see where we are. So we that's my initial treatment, my
Okay.
resuscitation,
Yeah.
so to speak. So I'm going to resuscitate him with fluids, antibiotics. I've got all my cultures in the lab, and I've seen my chest X-ray, and I do want a CT chest. And I appreciate
Okay.
that mine straight away, but I think we've got a reasonable ask here. If we said on the request, patient comes in with fever, tachycardia, and a productive cough, unusual chest X-ray appearances with nodular opacities on both lungs, not consistent with consolidation. Query
Mhm.
nature of opacities. I think that's a pretty decent thing. But what could be causing it? I'm not getting the sense these are
Mhm.
great big solid Mets, or are they sort of perihilar? And could they be big lymphadenopathy, for example, a new diagnosis of lymphoma? Was there any sort of geographic distribution that would hint towards those diagnoses?
They weren't perihilar, they were on the peripheries of the lungs, to be honest, rather than the
Mhm.
central. He did have a CT chest.
Okay.
Now, the CT chest showed that it wasn't consolidation and confirmed that these were nodular opacities. And it looked like there was some, within, I'm trying to think of the word's completely gone out of my mind. Um, oh my word, what's the word where it's like
Well,
crumbly inside?
caseating, necrotic.
Caseating, necrotic. Oh God, I'm so sorry. Yeah, I just might be crumbly.
Okay.
Yeah, we don't use crumbly, we use caseating or necrotic changes within.
Positive.
However, when the CT was done, the CT chest, it also picked up the liver. Now, the liver was reported as also having subsesses within it.
Mm. Mm. Could you add some LFTs onto those bloods you sent earlier, please, and let me know the results?
I can add some LFTs on, yeah.
Thank
The
you very much.
bilirubin was 48.
Elevated, yeah.
Yeah, and the alkaline phosphatase
Yeah.
was 210,
Okay, that's up.
and the ALT
Yeah.
in the 400s.
Okay. All right then. So all of those parameters are up. It's not clearly pointing towards a cholestatic or hepatocellular sort of picture. They're all just a bit rubbish, really. And
Mm.
liver abscesses, they said on the CT.
Mm.
Okay.
Yeah, two.
Okay. Is this someone who has got risk factors in terms of he's not immuno compromised anyway that we know of?
No, he did have a
No.
HIV test. HIV test was
Mm,
negative, and
mm.
the hepatitis screen was also negative.
You mean viral hepatitis screen?
Viral hepatitis screen was
ABC.
negative.
Is this someone who spent all their life living in the UK, or had they
Yep,
been? Is there a travel history we need to know about?
no recent travel.
Okay, no sort of swimming in fresh waters. He might have picked up any kind of amoebic infections or anything like this. No.
No, nothing to suggest schistosomiasis or anything, any form of amoebic abnormality. Dental
Okay.
though.
All right then. So we've got no important from the infectious disease history. And did we have a look, by the way, at his joints, his shoulder and his knee and his thigh? Was
Good.
there anything to see there?
Excellent. So, on examination of his joints, his right knee is very, very swollen, very red, very hot to touch, and very fluctuant. And actually, he can't move that knee at all.
Oh, oh no. Okay.
He's also got the same problem in the right shoulder. So the right shoulder is incredibly painful to touch, swollen, red, and also unable to move due to pain. The right thigh is also painful and swollen and tender.
So the knee, it sounds like certainly what you can't move. It sounds like septic arthritis, a septic joint.
Yeah.
Emergency, emergency. That needs to be tapped ASAP.
Hmm.
So I think we need to urgently organize someone to get a needle into that joint and see what comes out of the knee,
Hmm.
because this could be a limb-saving intervention.
Okay, yeah, absolutely. So that was done. I'm not going to give you the results of that yet, but the knee aspiration was done and it didn't look too bad. I always think knee synovial fluid looks quite viscousy, quite clear. It's almost the colour of urine, to be honest, like pale urine. But it wasn't particularly cloudy. You
Right.
couldn't see anything floating on it. There was no blood in it. Sometimes you can get blood hemothrosis, or it can be the fact that you maybe just hit a vessel on your way in or on your way out. But that was certainly done very, very quickly. And it was
Okay.
sent off for gram stain and microscopy, culture, and sensitivity.
So that's cooking.
Yeah.
What would cause two distant joint infections and liver abscesses and possibly lung abscesses as well? So we're thinking of some kind of disseminated infection. I've seen Klebsiella do this before. I mean, I've seen disseminated gonococcal infection do this before on an immunosuppressed patient. So I think the only part of the infectious disease history I haven't asked about is a sexual history.
Hmm.
So we ought to do that. Endocarditis, I guess it's not unreasonable. They could throw off septic emboli, which could travel hematology, not hematologically, that's a terrible word, via the bloodstream to distant organs. So blood cultures, knee cultures, and broad spec antibiotics, maybe in conversation with microbiology. We ought to get a sexual history. We ought to make sure there's no concurrent symptoms of an STI. And what else do we need to do? I think we ought to, if they didn't yield the diagnosis, then would these very peripheral lung lesions or liver lesions be amenable to aspiration and drainage? Or would they want any further imaging, dedicated imaging of the liver before they made that call, such as an ultrasound of the liver? That's what I'd be thinking now.
Okay, fab. So you're right to mention infective endocarditis, disseminated infection, had an echo. It was a transthoracic echo, which was normal. There
Mm.
wasn't any sign of any abnormalities. However, obviously, you probably would need a transesophageal echocardiogram if you wanted to really look for endocarditis, but there was nothing, so that wasn't done. You also mentioned maybe thinking about the lung and the liver lesions, maybe trying to get some fluid out of them. So that was certainly something that was discussed as well. Now, they were done. So a lot of the cultures were done, but they take time to come back, don't
Mm.
they? So even when you're doing a gram stain, you may be waiting 4, 6 hours. And certainly if you want to do a culture, that can take 24, 48 hours. So is there anything else that we can do to have a closer look at the joints whilst we're waiting for those?
Closer look at the joints. Well,
And the thigh. Remember, the thigh was incredibly painful.
so we can do, if we look through a thigh soft tissue, so the best modality for looking at that would be an MR.
Okay.
And I think plain X-rays of the knee are important because you'd be looking for erosion and
Hmm.
destruction of joint space.
Hmm.
Only two thoughts.
Yeah, so all possible. Now, the MRI, it wasn't available for some reason. So we had a CT because that was what was available at the time. And he had a CT of the thigh area and also of the shoulder because it was thought that that may yield some information. Now,
Hmm.
the CT showed a large intramuscular abscess within the quadriceps femoris.
Hmm.
And the CT of the shoulder showed intramuscular abscesses in the right subscapularis, infraspinatus, and teres minor.
Okay, that sounds painful. So all his rotator cuffs. So this is a young man who's just riddled with abscess
Absolutely.
in his
Yeah.
musculoskeletal system and in his vital organs.
Yeah.
Due to an unknown organism. Okay, this. I think at this point we're at the mercy of the lab's returning culture results,
Hmm.
and an ID consult. I think would be a very very
Yeah.
pertinent point as well to see if they come up with any clever ideas. But in someone who has not traveled, does not undertake high risk behavior for any particular infectious diseases, and has a competent immune system,
Mm.
um, yeah, this is a real puzzler.
What about the sore throat? Does that mean anything or?
Sore throat, you tend to think either viral
Mm.
infections, up to
Mm.
including EBV, but also bacterial infections would be strep A is the big one for throats. Disseminated strep A, never heard of it. Oh, hang on a minute. You can get there are invasive groups of strep A which can cause severe infections,
Mm.
soft tissue infections, as well as sore throats. I never heard of them doing liver and lung abscesses though.
Okay, so the blood cultures came back and they were negative. They looked at TB, T is negative.
I
Bron-
find.
Bronchoalveolar lavage was done, which was negative. And the knee and the shoulder aspiration was negative. Now, some clever interventional radiologist was able to get some sort of pus fluid out of the liver lesion.
Yeah.
What do you think it might have grown?
I don't know.
This is tricky. This is
I
tricky.
don't know. Is it going to be something completely random like Brucella or something? I have no idea.
So it grew Fusobacterium necrophorum.
Yeah, I was never going to get
No, well, so you never know sometimes.
that.
So, what have you heard of that in the before, and why
Fusobacterium necrophorum.
forum?
No, I like words. So Fusobacterium necro doesn't sound good. I mean, that's
Mm,
that sounds
mm,
like necrosis and necrotic and other
mhm,
words relating to death. But
mhm.
no, I do not know that particular name.
So it's a gram-negative rod. It's an anaerobic um, bug, and it likes to live in the alimentary tract. Now, this gentleman was really sick and went to the intensive care unit, and they requested a neck Doppler. Now that is the key.
Right. And they did they request that because there were signs or symptoms there, or they were just looking?
They were looking at the neck.
Did they find a septic thrombus of the jugular vein in keeping with Lemierre's syndrome?
You did it.
Oh,
Ah,
get
Ben,
it.
that's amazing. Yeah. Yeah, this was Lemierre syndrome.
I've only ever seen that cause profound symptoms,
Mm,
local symptoms, the neck, engorgement and
mm,
obstruction. So I'm surprised that that wasn't a feature of it. How interesting.
mm. So it used to be called, well, it was until recently called the forgotten disease because it hadn't been seen
And
for
I've forgotten it.
so many years. So, hold on, yeah.
Yeah.
Um, and I guess because antibiotic usage has rightly so decreased for tonsillar infections over the last 20, 30 years, we are starting to see a few more cases. Now, it tends to occur in young people between the ages of like 18, 25. It's very rare though, and it does have
Mm.
quite a significant mortality rate. Now, what's really interesting about Lemierre's is that it often starts in the throat. So, oropharyngeal infection, which spreads into the soft tissues of the neck and the pharyngeal space, which is where you can sometimes get those signs, that tenderness. However, this can trigger off thrombosis in the peritonsillar vein, which causes, as you rightly said, the internal jugular vein thrombus. And that's why we scan the neck.
Did
So,
he have any local lymphadenopathy, cervical
yeah,
lymphadenopathy?
there was some subtle cervical lymphadenopathy,
Right.
but not really bad. And
Mm.
what had happened in him is obviously because he'd got all of this inflammation. What's very specific about Fucibacterium necrophorum is it causes platelet aggregation, triggers off coagulation, plus inflammation, you get lots of septic emboli. And the thought process is with all of these septic emboli, it basically disseminates the bacteria throughout the body, joints, soft tissue,
Mm.
liver, lungs, which has happened with this gentleman.
And that explains it then.
That explains it. Yeah.
Do you know, the reason I know it, I thought of it just then, is because I used to be the co-editor of the Acute Medicine Journal, and one of my remit
Mm.
was to review the case reports that came in. And I just suddenly remembered a case report that was submitted, and we think we published a while ago, which was similar to what you're doing. I mean, so this is the power of the case report. They've always been my favorite part of journals
Me
and
too. Yep.
conferences. And I guess what we're doing here is a case report podcast,
Yeah.
essentially. But
Yeah.
I find it's a really good way of sticking things in my brain because
Mm.
you attach them to a narrative, to a patient, and I'm much more likely to recall it that way, which worked today, eventually, with
Yeah.
much prodding.
Yeah, but the fact that you got there, and actually this case took quite a long time to solve, and you
Yeah,
did it in 20, 30 minutes. Obviously with all the investigations, but we got
yeah.
Very rare. I've only ever seen one case in my
Yeah.
whole career, and it's not something that we're probably going to see much of, but it's certainly something to be aware of because of the high mortality and morbidity that is associated with the condition.
So this is something to think about when we see someone with basically disseminated bacterial infection, usually in the context of a sore throat as the antecedent history.
Hmm.
But if they have infection everywhere that doesn't quite connect, and we're thinking that some kind of bacteria is coursing through their vasculature, seeding distantly, then this is something that should be on our radar as the source.
Absolutely. I've
Got it.
seen a very similar case that was due to infected endocarditis caused by Staphylococcus aureus in an
Mm,
intravenous drug user. And that's,
mm,
but it wasn't, it was obviously Staph aureus, not Fusobacterium, but was very similar with the septic emboli.
mm,
Um, yeah, very interesting. And management is very supportive with antibiotics. They suggest tazocin is a good antibiotic, but again, it's very broad spectrum. Plus or minus metronidazole. And if you can, drain the pus. Because if you've got,
mm.
lots of collections of pus, antibiotics aren't going to be able to get into that cell wall. So that's another way of helping them. But the mortality rate is, as I've said, pretty high. It can be between, I think it's like 6 and 18%. So,
Mm. And I guess one question I'd be interested in, and maybe you don't know, is anticoagulation. If there
ah,
is a thrombus there, which is
hmm. It's
therapeutically or
debatable. So it's
yeah.
debatable. So when you look at the case reports and you look at the research around Lemierre's, some people say to anticoagulate, some people say not to anticoagulate. And some people say if you anticoagulate, it can worsen. I mean treatment dose anticoagulation, not preventative. It can actually worsen the mortality and morbidity associated. So there's no clear consensus on whether to use treatment anticoagulation or not. So
Got
quite
it.
consensus.
Thank you very much. That's going to stick, I think, in my library
Yeah,
now. That's in my brain. So thank you so much for
yeah.
sharing that. I really enjoyed that.
And it's a good one, isn't it? It's like your case of do you know what? Oh my word, I'm one of those
I
days
was going
today.
to say, I hope you're not using this as an example of a case you want
Oh, do you know what? I'll
to
blame the
stare
extreme
at me
heat.
blankly.
The one with the multiple clots within the leg that my brain has just again forgotten.
Oh, you mean pathological DVT,
Yeah.
cerulean dolens, phlegmasia cerulean dolens. Yeah.
Phlegmasia cerulean
Yeah.
dolens, exactly. And I was just about to say I always remember that one, but I clearly didn't. So that's very embarrassing.
Write it down. Write it down.
Exactly. So, loads of takeaway points there. And I hope that that will help, even if it's just one person, get diagnosed with that condition when that diagnosis may not have been made. So, massive thank you to everybody for listening. Please, please, please subscribe to the podcast and rate and review our podcast. And any feedback is welcome and get in touch with us. Thanks for listening.
Bye.
Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.